Hey, welcome to the Adventures in Brain Injury podcast. My name is Kevin Ballister. I'm a severe traumatic brain injury survivor, author, speaker, neurotrauma medical advocate, and I'll tell you more about that in this episode. And I am so excited to be interviewing Laura Bedell. She's a registered nurse in ER and critical care for over 42 years of experience in New York City. And she currently works at the second hardest hit COVID-19 hospital in New York, which makes it the second hardest hit COVID-19 hospital in America. She is phenomenal, and getting her experience from the front lines of this pandemic in America is so powerful. You know, she is an absolute expert on her perspective, as everybody. You're an expert on your perspective. I'm an expert on mine, and she is rocking her perspective and really tells you what her experience is like there. So I'm so excited to bring this to you, to give you some perspective. And if you're enjoying these, just head over to iTunes and leave me a review. Or if you hate these, head over to iTunes and leave me a review. You can get there, feedtobrain.com/iTunes. All right, let's hop into it.
It's a pleasure to be here to speak with you.
That's Thank you so much for taking the time. I know you're busy anyways, and now you're probably a little more busy with where you're working. So first, what hospital do you work at?
So I work for New York Presbyterian, Queens, in New York City.
All right, and you're in the ER department?
I am. I'm an emergency room nurse.
All right, and you were telling me that is the second hardest hit hospital for COVID-19.
It is. I know on the press, people, in New York and around the country probably heard about Elmhurst, Queens, which is the biggest city hospital in Queens, and they had huge numbers as well. We were right up there with them.
I want to give a shout out to Elmhurst. After my brain injury, that's where I was taken, was to Elmhurst. And and a shout out to Dr. Scott D. Weingart, who has a podcast called the MCRIT podcast for emergency critical care, and he is a phenomenal emergency physician. So just a little sidebar, I want to give a shout out to Dr. Weingart. So Laura, what brought you into nursing?
I don't actually remember making a conscious decision to be a nurse. I always felt like I was a nurse. I had a family situation where I had to care for my mom when I was little, and until she passed away at a fairly young age. And actually, when I went into nursing, I thought I always was drawn to emergency type situations, and I thought I would become an Army nurse, a field nurse. And while I was in college, my intent was to be an Army nurse. The Vietnam War was still on. And while I was in college, my last year of college, actually my first year of college, Saigon fell and the Vietnam War was over. And my mother still needed a lot of care, and I couldn't just go. So I turned I just became a nurse and started working in a hospital.
And where did you grow up?
I grew up in Astoria, Queens.
Okay. So,
yeah.
So in Queens. Okay, and so you've been a nurse in New York City for many years, for 42 years, right? And so you've worked through several virus scares. Can you recall one of those virus scares?
Honestly, I think the first really big viral scare that I was exposed to was when HIV/AIDS hit, and that was my first exposure to a major communicable disease that was deadly. And now, of course, we all know people who live with HIV/AIDS and who have long, healthy lives. The drugs that have been found since then you know, they do wonderfully, they do beautifully. But back in the day when I was first seeing them, everyone who got AIDS died.
Right.
So it was scary. They didn't know how initially it was communicated, and of course all that came to light, you know. And yeah, so that was my first experience.
All right, so I bring that up to relate it with COVID. You said everybody who had HIV died, and now people with HIV don't die. People are able to live long, healthy, happy lives with HIV.
Mm-hmm.
And thinking about COVID right now, everybody doesn't die who has COVID, right?
Correct.
So however, you're at the second hardest hit hospital in New York City, and in fact, New York Presbyterian Queens is one of the hospitals that erected a refrigerated morgue tent, or several
Mm-hmm.
refrigerated morgue tents outside in order to make room for the dead bodies.
Mm-hmm.
So, could you
Mm-hmm.
tell me a little bit about the progression of your experience as an ER nurse in the second hardest hit hospital in New York City?
You know, we heard about this virus in China, you know, and come January, I guess, you know, people started talking about, you know, well, you know, it could come. I guess it was end of December into January when Italy got hit, and people started sitting up and taking notice. By February, there was rumbling, you know, about what was going down. And then I guess it was early March when we started getting hit, and it peaked in April. It wasn't even gradual. It was like we heard, you know, we were going to be getting these patients, and suddenly we had them. And then suddenly it was like whoosh. It was like a tidal wave of really, really sick people. And all at once, you know, and then they poured through the doors. And then as the media, you know, gave it more and more press, more and more people with vague or minor symptoms started pouring through the doors.
So when you were talking about the people who were pouring through the doors, what was their health like? And who was at risk to begin with?
Well, what we found now in retrospect, and even while we were in the middle of it, that yes, certainly elderly, certainly people who were immunocompromised because they were on chemotherapy or because they had an underlying illness, people who overwhelmingly they had either a lung issue because like COPD, emphysema, congestive heart failure, people who had heart conditions of any kind, diabetics, and overwhelmingly many obese people, which made sense because most obese people have those comorbidities of high blood pressure, high cholesterol, diabetes. So they kind of go hand in hand.
Right.
But that's not to say we were not seeing young people. We had many young people in their 20s and 30s and 40s who were very sick and who were no health problems at all.
So what about newborns or children?
We did not have, to my knowledge, many children. From what I have read and seen, and I have friends who work in other hospitals in New York City. Yes, they did get children. They've had children as young as newborns in the NICU who tested COVID positive. They had mothers who were COVID positive. And so, because they, you know, doctors wondered, if they're pregnant, is it going to cross the placental barrier? And yes, it did. They didn't know ahead of time, but yes, children tested positive. But far and away, the children did very well with it. Thank God.
Yeah.
They did well. Certainly compromised children with underlying respiratory issues like cystic fibrosis, it was a higher danger for them should they contract it because they were already compromised. But far and away, the children did well, and not many got infected. So that was a blessing.
Okay. All right. So you're talking about how they tested positive, and I'd love to talk about the testing for COVID-19. So what is it? What is it, and how well does it work?
I know that the tests that we had the first week were we were getting a lot of false negatives. And it's a nasal swab, but it's not, you have to put the swab in. It's a nasopharyngeal swab. So you have to go all the way up the nose till you hit the back, so the swab can't go any further, and it's actually hitting the upper part of your pharynx. So I think there were some tests that were poorly rushed maybe to production. I think there was some that were maybe poorly executed, that they didn't go back far enough. They seem to have improved since the beginning of the virus came, since the virus broke.
Well, that sounds really uncomfortable.
Yeah, it is.
Yeah.
Mm-hmm.
Okay, so with the testing, so there's quite a few false negatives, and there has been false negatives. And how can you tell they're false negatives? I think you told me that you can tell on a lung X-ray.
Right. So we had, and it happened to coworkers of mine, that they had symptoms and they were tested and they come up negative. And they're like, it makes no sense. Like I have all the symptoms. And they would test. I had one friend of mine who tested negative twice and continued to progressively get sicker and came to the hospital. And when they did the chest X-ray, it showed on the chest X-ray that they were positive, that it was a classic COVID chest, a classic, they call it like a COVID pneumonia. It's not like a classic pneumonia where it's just pneumonia. It's the COVID pneumonia presents on a chest X-ray as a whiteout of the chest, and they call it almost a ground glass effect on a chest X-ray.
Gotcha. So the chest X-ray is kind of where you actually know if it's a COVID lung. That's a specific look to
yes.
it. Okay.
Yes, it has a very specific look to it. Yes.
Okay.
That and also some blood work as well.
Okay. And what sort of blood work? What do you see in the blood work?
Well, in the blood work, there's certain markers on a chemistry panel that you run on a patient, and certain markers that show that there is indeed an inflammatory response going on in the body. It's classic to COVID. They'll see their clotting times are increasing. They'll see their lactic acids are increasing. They'll see their ferritin levels are through the roof. And a ferritin level is in direct response to, it shows an inflammatory response in your body. And so, a normal ferritin level it can go as high as 400. We were seeing people with ferritin levels in the thousands.
Wow.
And so those were classic markers as well.
Okay, so did you say clotting times increase?
Right. In other words, it's taking was shortened rather. I'm sorry.
Okay.
Your clotting times were shortened, and we didn't initially in the beginning realize that these people were clotting so badly, and until we started seeing their it's a test called the PT-PTT. It's what measures your clotting times, and then we started seeing, look at these clotting times. They're totally abnormal, and then we started seeing sudden death, like a person who would be, gradually getting worse would suddenly just die of an arrest, or just respiratory arrest or cardiac arrest, or they would throw a pulmonary embolism. And then we're like, oh, this is causing clotting. And unlike many other diseases, for example, like Ebola causes hemorrhaging. And many of the classic diseases in history were hemorrhagic. But this was totally different. And that's why they call it a novel virus, because it is novel. We've never seen anything like it.
Mm-hmm. So
and so these people would form clots, massive amounts of clots. And even now, they have patients who have been sedated on a ventilator, and now they seem to be improving. So they're weaning them off the ventilator, and because they've been paralyzed and sedated, there's no way to do an accurate neuro check on them. And then when they wake up, they have paralysis on one side, and they said this patient stroked while they were sedated and paralyzed.
Wow. So it's creating clotting. Where is that? You said stroke. That's when clotting happens in the brain.
Correct.
So,
And these clots can form anywhere and go and affect any part of the body. Any part
wow.
of the body. They can go to the lungs, the heart, the brain. There's a Broadway actor right now who's I don't know if you saw him in the news, but he lost his leg because he had a massive clot go to his leg. He lost the circulation and he wound up losing his leg because of it.
So the clotting happens anywhere in the body, uh,
Hmm.
but this is my understanding is it's a respiratory condition.
Well, this is what we thought. We
Okay.
thought it was a classic ARDS, acute respiratory distress syndrome, or SARS, or MERS, Middle Eastern, respiratory syndrome. We thought that's what it was. It turned out to be much, much more than a classic respiratory. Yes, it's your lungs that wind up because obviously you can't breathe, you can't live, you know. Um, so it does attack the lungs, but it attacks so much else as well. If it was just confined to the lungs, maybe we'd have more success, with some of these people who didn't survive.
So you're talking about the COVID lung, the COVID chest, and how that presents itself with this ground glass look and completely whited out. And I wonder, is that the clotting happening in the lungs?
You don't see clots on an X-ray. You would have to do a specific test to look for clots in a
What
lung.
about
Um,
autopsies?
you'd have to do a CAT scan with contrast to find clots in the lung.
Hmm.
But on a regular standard run-of-the-mill chest X-ray, the whiteout is created because when you think about it, when you take a chest X-ray, what you see is black. It's basically black. You see the outlines of the lung because air is see-through.
Hmm.
When your lungs are collapsed or stiff or not inflated with air, they white out. All the little alveoli in your lungs are collapsed and they become opaque on X-ray. They're not filled with air. You can't see through them. So that's why it appears as white.
Wow. So do you think that's because of the clotting? Do you know what that if they've seen that in autopsies or anything of that sort?
Do they see what on autopsy? The clots or the white out?
Well, the clots. Yeah, we were talking about autopsies showing blood clots in the lungs.
Yes,
S-
you do find that in autopsy. I read an article recently about a patient who had a large pulmonary clot, and the doctor went in to pull the clot out, and he said that he could see in real time while he's pulling the main clot out to save the patient's life, new clots forming in real time in front of his eyes.
Wow.
Yeah, yeah,
So the disease essentially increases the speed at which the blood coagulates and blood clotting
correct.
happens. And
Hmm.
so let's talk about some treatments for COVID-19. What are some of the
Hmm.
treatments that are currently being done?
Well, it depends on what stage of the disease the patient is in. Um, if it's early disease where this is a patient who's presenting like flu-like symptoms, they're doing vitamins, they're doing zinc, they're doing vitamin C, they're doing vitamin D and B, and they were giving oral azithromycin, and they were giving oral hydroxychloroquine.
Um,
And sometimes it worked, and sometimes it didn't.
hydroxychloroquine.
Hmm.
What is that?
Well, it's an anti-inflammatory drug. Patients who have rheumatoid arthritis, lupus. It was initially, I believe, it was initially discovered as a treatment for malaria, and then they found it had useful. It was useful in other diseases. Um, I'm not sure of the chemical, compound in it that why they thought this would be good for COVID. By and large, it was a hit and miss thing. People got it, but it wasn't doing much.
Gotcha.
People did it because and in certain people, hydroxychloroquine can be toxic. So it wasn't ideal, put it that way.
Okay. And then you talked about how the clotting factor is increased a lot, and it takes much less time for blood clots to form. And so
Hmm.
what about anticoagulants?
Everybody who had advanced to that stage of the disease were put on anticoagulants intravenously, and they have to be carefully monitored, because you don't want to increase their clotting time so much that they would hemorrhage. So they have to be carefully titrated, to maintain, a good level. But even despite running those kinds of medications, people still would form clots.
Okay, and then at the same time, if we're at that stage, are they also using the antibiotics?
They are. Anybody who is bedridden, okay, like for instance, your nursing home patients, okay, who do not have good mobility, and they are prone to diseases that come up simply by being inactive, okay? They don't, fill their lungs with air the way we would if you're walking and you get out of breath, or you run, or you just do any kind of exertion. So similarly to people who are inactive, they're prone to getting pneumonia. They're prone to getting urinary tract infections. Anybody who's on a ventilator, bedridden for days or weeks, is prone to getting a secondary infection, because they cannot clear their lungs. Their lungs actually, with the COVID, actually become stiff. And so the antibiotics were given not because the initial infection was bacterial in nature, but to kill off the bacteria now that has no place, no way, no capability of leaving the lungs. So they would give antibiotics to kill it off. Same thing with healthy, active people, in early stages, they would give it orally to prevent a secondary bacterial pneumonia from setting in.
Okay, so even though it's a virus, it's treating or preventing a secondary infection.
Correct.
And what about actually, while we're on antibiotics, and you talked about flu-like symptoms. So
Hmm.
flu-like symptoms, like they're very very similar symptomology in the very beginning. Um, and was curious about the similarities and differences between the conventional flu and COVID-19.
Typically, with a true flu, you will feel fine on Monday and wake up Tuesday and you're like, oh my God, I can't get out of bed. Like, my whole body hurts. You may or may not be feverish. You eventually become feverish. It's fever, cough, body aches, headaches, like that. And you may sweat at night, that kind of thing. And so you feel awful, and you feel awful, and you feel awful. And then as the days go by, it goes away. With COVID, in many patients, they would just have like, I have this dry cough for like 5 days now. And then maybe 7 days in, they while what they're feeling is similar to a flu, the presentation, the speed, all of that is not, it doesn't correlate. And then after 5 days, they'd be like, you know what? Now I'm starting to have a fever. That's not typical flu. And then like a few days after that, they're starting to feel tightness in their chest or shortness of breath. That's not typical flu. Sometimes, I had an elderly gentleman who came in, and I said, how are you doing? And so this particular gentleman was in his 70s. He said, Wednesday, now I was taking care of him on a Friday. He goes, Wednesday, I woke up with a cough. He said, and I was like, just a little cough. Thursday, he started running a low-grade fever. And by the way, just as a caveat, all this fever testing, 50% of patients with COVID don't even run a fever. So all this thing about checking people to see if they have a temperature is not accurate. So anyway, he was saying to me that on Wednesday he had the cough. Thursday he started running a low-grade fever. And that day that I got him, that Friday morning, he was starting to have difficulty breathing. So his wife said, you better go in. You better go in. And so I'm taking care of him. And, he was short of breath, but he was doing fairly well with a mask on his face. And within 1 hour, he decompensated. He couldn't breathe at all. And we wound up having to intubate him. And so that's not flu. This man was overweight. He was diabetic. He did have an underlying heart condition and hypertensive. So he was the classic, high risk group.
Wow. Okay.
Yeah.
And so intubation, could you tell me what intubation is?
Okay. So intubation is the introduction of a breathing tube into your trachea, and it's inserted in your trachea and it goes down into your lungs, and then you're attached to a ventilating machine, which does the work of your lungs for you.
Yep, I can totally relate to that. I absolutely intubated at least twice. And I know they were suction fluids for my lungs as well. So it's a type of ventilator that actually breathes for you. And
correct.
I know that there's other ventilators, such as a BiPAP, that isn't shoving a tube down your throat, but instead it's a face mask that goes over. And the thing is, well, we haven't talked that much about the contagious factor, so let's do that real quick. Let's talk about how COVID-19 is contagious.
COVID is transmitted through your respiratory system. Okay, the virus is inhaled or transmitted to your mucous membrane. If you touched something contaminated that a COVID droplet fell on and then touched your face, you can inhale now that virus, and it gets into your nose or your mouth, and that's the primary site where it enters your body. So in the case of the COVID lives in your lungs mostly, and so even though it's transmitted in a droplet form, like by coughing or sneezing, when a patient's intubated, you have literally, the air in your lungs or my lungs right now is not affecting anybody. If I was to put a tube down, anything in your lungs would come flying out in the air. So it's considered a very high-risk procedure when you're intubating, because you've literally opened up the doorway to the hornet's nest when you're putting that tube down into the chest. And so anybody in proximity will be breathing COVID air. So they hook them up to a closed system to ventilate them as quickly as possible once the tube is introduced.
And it needs to be a closed system. My understanding is a BiPAP is not a closed system. And it needs to be a closed system so that the exhale, I'm told that it's transmitted through droplets, through liquid droplets.
It is transmitted through liquid droplet. When a patient's having respiratory distress, you can put a non-rebreather mask on them, which is an oxygen mask, okay? That's very passive, an oxygen mask. The patient's breathing, but the mask is on their face and they're inhaling oxygen. A step up from that would be BiPAP. Now, BiPAP is an oxygen mask that's fit tightly on your face and attached to a machine. An oxygen mask is simply attached to an O2 spigot on the wall. A BiPAP is attached to a machine, and it's forcing air into your mouth and your nose. Typically, a patient on BiPAP has to be alert because they have to cooperate with the machine, in order for the machine to be effective. That mask is tightly sealed on the face, but there is blow off on the machine. It has like little vents in the mask, and it has you can't get a perfect seal, every wrinkle of your face. And so the thinking was that blow off can now aerosolize those droplets into the air surrounding the patient. And generally, I'll say this, generally with COVID patients, BiPAP was not used, generally. They couldn't tolerate it. The blow off from it was too dangerous. And in an ideal setting, if every patient could be contained in a private room and put on BiPAP, maybe. But even then, picture it, it'd be like putting them in a single room, and now this BiPAP machine is blowing off COVID in the air, whereas before you just had to worry about droplets, right? And now that room is so contaminated that every time you open the door, you are now releasing it.
I see. Yeah. So, okay. So it's not a closed system. And
It's not totally closed the way intubation is.
I
Right.
think you probably want a closed system to prevent aerosolization.
Well, you want it because of that and because it's the best thing for the patient.
Right.
That's not to say it's going to save their life, but it's all we've got. It's the last resort to save their life, you know?
So you say it's not. So when patients are put on a ventilator, are intubated,
Yes.
what's the percentage of those who survive?
I've read mortality rates were as high as 80%.
Meaning 80% died.
Correct. Who progressed sick enough to be put on bypass.
Gotcha.
Yes.
So, yeah, it sounds like, and we talked about this earlier, but it sounds to me like the ventilators aren't working. And what we talked about earlier with the blood clotting and blood clots in the lungs, I would assume those are preventing the lungs from absorbing oxygen.
It's that the longer a patient is ventilated, not in regular diseases, but I'm talking with COVID, the longer they're on a ventilator with the COVID, the lungs become stiff. Healthy lungs are soft and pliable, and they become stiff. And the air sacs in your lungs, they actually collapse and they stick together. And you can't inflate them. And you combine that with a blood clot, and it's deadly.
So I wanted to talk with you about some other treatments. Something a lot of people are very excited about and looking to have happen is a vaccine. A lot of people are waiting for this vaccine to come. And I want to talk to you a little bit about the vaccine, what your experience is with vaccines, and how long it would be for vaccine to be made. So I guess first of all, would this vaccine be at all similar to, say, the flu vaccine, do you think?
The easiest way to explain it is that, you know, regular seasonal flu is the same virus that we've seen year after year after year. But every year, the virus mutates and changes up a little bit. So there's always different strains of flu on any particular year. So they can only, they can only get effectiveness for a certain percentage of the strains that are in any given year. And so if you happen to have one of the strains that, is a little stronger, that the vaccine doesn't attack, you're going to get the flu anyway. I'm dubious about them even creating a vaccine for this thing, because this thing has so many different faces, even within the scope of the people who were sickest. Some people went down a more respiratory path. Other people went down a more sepsis path. Other people went down a more blood clotting issue path. I would be very skeptical about a vaccine that would cover the sickest of the patients. What they are having, funny enough, because we started out this conversation talking about, my exposure to AIDS, is one of the antivirals that came out for AIDS. They are now having some limited success with in COVID patients, and that's the remdesivir.
What was that? The RAM what?
It's called remdesivir.
Okay.
And I actually, one of the articles I read was saying that a gentleman on a ventilator who was in his 40s and very healthy, the remdesivir saved his life, they believe. But now what I'm hearing now is that possibly giving remdesivir early in the course, before symptoms get terrible, it could maybe stave off, it progressing to a more critical outcome.
Okay, well, let's go back to vaccines a little bit. What is your experience with the flu vaccine? Because I know you're working in healthcare. You're mandated to get the flu vaccine every year. Is that right?
Yeah.
And
So,
so are all your colleagues.
yeah, if you work in a hospital, you have to get the flu vaccine. The only way you can, refuse the flu vaccine is if because you have an allergy to something or because it's a religious thing. And if you are one of those people, you have to wear a mask from the beginning of flu season to the end of flu season. So yes, we are required to get a flu vaccine. Patients in nursing homes are required to get a flu vaccine. Okay, 40% of the patients from nursing homes with a flu vaccine get the flu anyway. 40% of the general population will probably get flu if they've had a vaccine or not. No, I should say 40% of the people who get a flu vaccine are capable of getting the flu anyway.
Okay, and then the flu vaccine is only 60% effective.
Right.
And
the flu vaccine you get this year is not going to be effective for next year because it'll be a different strain.
right, and that has to do with the mutation of the virus.
Right.
So COVID, does that also mutate?
Yes, and as I said, by one estimate, it's mutated 30 times since it first appeared in Wuhan.
Wow, mutated
Right.
30 times in
30 times.
What was that? December? Since December?
Correct. Well, that's when we found out about it. It was apparently, started in China in early December, and they say it's mutated at least 30 times, and depending on which would make sense in that so many people say, yeah, I had it, but I recovered, and it was, I was fine, and so they obviously got a mutation of the virus that was less severe than somebody else got. Coupled with comorbidities, and there you go.
So you talked with me about plasma transfusions of people with adaptive antibodies for the virus.
Right. They're encouraging people now to get tested, not only to see if they were positive, but also to see if they made antibodies. Some people have antibodies and never had any symptoms. So that shows that they were exposed, and for whatever reason, they made antibodies. If you're a person who had been sick and made antibodies, they're encouraging those people to donate their plasma, and they're transfusing that to people who are sickest, who are ventilated, kind of like as a last-ditch thing, hoping these antibodies will kick in and kill this thing, I don't think it's been around long enough for, any good studies, to see how good. Sometimes it works, sometimes it doesn't, kind of deal, and so they're going to be sorting this out for probably years to come. The confounding thing about this virus is that I've had friends who tested positive, and so they went to go have their blood drawn to see if they had antibodies, and half of them made antibodies and a lot of them didn't. They just didn't make antibodies. And then, so now the question arises, well, could you get it again if you didn't make antibodies? Would you? And if you did make antibodies, are you immune? And if so, for how long? It's all question marks. We live in a society right now, even go before COVID, there was the thing of, Purelling your hands, and cleaning your hands with alcohol. And prior to that, all we did was wash our hands with soap and water, and everybody in the world was exposed to things on a daily basis. You get on the subway, you go to the supermarket, whatever. And so purists would say, people, your body will adapt to natural bacteria in the atmosphere in your daily life, and it's a way to build up immunity to certain things, where if you're constantly killing off the good with the bad, your body never has a chance to kill off anything and make antibodies for things.
Right. Yeah, we've talked about hormesis being the therapeutic introduction of a toxin, which essentially is the basis of what vaccines are utilizing, is having the introduction of a toxin that our body can handle, and in having that threat that is manageable, we build
Yes.
our resilience to those threats.
Right.
I wanted to chat with you about we talked a bit about the nutrients that they're giving people, and
Mm-hmm.
I sent you a study that I found. It was an article published in Elsevier Public Health Emergency Collection, and it
Right.
said that high dose intravenous vitamin C has also been successful used in the treatment of 50 moderate to severe COVID-19 patients in China. The doses
Mm-hmm.
used were between 10 grams and 20 grams per day, given over a period of 8 to 10 hours, and additional bolus might be required among patients in critical conditions.
Mm-hmm.
Said that the oxygenation index was improving in real time in all patients,
Mm-hmm.
and
Mm-hmm.
all the patients eventually cured and were discharged. In
Hmm.
fact, high dose vitamin C has been clinically used for several decades, and a recent NIH expert panel, NIH is the National Institute of Health,
Institute. Yeah.
an NIH expert panel document states clearly that this regimen, 1.5 grams per kilogram of body weight, is safe
Mm-hmm.
and without adverse events.
Right.
So, are you seeing IV vitamin C in hospitals? Is that part of the
No.
standard of care?
No. No. And I wish we were, because and again, it's my personal feeling that it would be beneficial. I'm a big believer in vitamin C. My own personal feeling, and I have read scientific reports to back that up. I can't answer to why they're not using it, but it's not only my institution. I know of no institutions here in the States that are using IV vitamin C.
Right.
If there are, I would love to hear about them.
Right.
But I don't know of any. But I do know that patients were given oral vitamin C, prior to getting very sick. If they could swallow tablets and they were awake and alert, they were giving oral doses of vitamin C. I think just as a thing to help boost their immune system or whatever, but not because anybody truly believes in, the efficacy of C, which I think historically has been proven,
Mm-hmm.
But I don't see any place using it.
Yeah, and in the research, it's shown to be very safe and effective. You were telling me about studies on sepsis, and as an ER and critical care nurse, you see a lot of sepsis, don't you?
Yes, especially in the elderly. The elderly either get sepsis in their blood, sepsis in their urine. It starts off as a regular run-of-the-mill urinary tract infection, but it progresses to sepsis because their body doesn't have the stores to fight this thing off, and they become septic. Or they have a wound from laying in bed that becomes infected, and then it becomes sepsis in their blood from the wound. And so, yes, it's mostly the elderly. And I did read a study that was done, a doctor someplace, I believe it was the Midwest, who, as a last-ditch effort, was using IV vitamin C and saw a very impressive reversal of sepsis in patients who were septic with IV doses of vitamin C. And he was in the process of publishing that and trying to get more people to stand up and look. I don't know where it stands on that.
Yeah, I did find some articles online about that, and this is a lot of what I do as a
Mm-hmm.
medical advocate. Is I read through the research, I consult with my network, and I find treatments that I think are really powerful. And we haven't actually
Mm-hmm.
talked about this yet, but
Mm-hmm.
but when it comes to the standard of care, like the standard of care is defined as the type and level of care an ordinary, prudent healthcare professional with the same level of training and experience would provide under similar circumstances in the same community.
Right.
And so if you're given a prognosis that isn't very good, and
Mm-hmm.
by the way, the standard of care was coined for malpractice cases, uh,
Mm-hmm.
because if a physician deviates from the standard of care, they're liable to be
Mm-hmm.
sued for medical malpractice.
Mm-hmm.
So if you're given a prognosis that is not good, uh,
Mm-hmm.
how would you like an ordinary practitioner to give you the same level of treatment that gets the same or similar results? And
Right.
that's what yeah. So that's the
Right.
last thing I would want is,
However, what everything you just said is absolutely true. However, if a patient's given any kind of a diagnosis, under the law, they're expected to have a certain level of a standard of care. Now, if you go to Dr. Jones and he tells you, I've tried everything within the standard of care. I mean, that's in the books for whatever disease you have, and nothing's working. He's now officially off the hook. And whatever you decide to try after that, he's not liable because he did his due diligence, that kind of a thing. But as a consumer, and you are a consumer when you're a patient, you have to assume some autonomy in your own care as well. But that's assuming that you are, I don't want to sound any kind of way, but you have to be somewhat intelligent. I mean, I can't tell you how many patients I get in and I'll say, and I'm triaging them, and I take a medical history and I'll say, any surgeries? And they'll say, yeah, I had abdominal surgery. What kind? I don't know. Well, did they remove anything? I don't know. They took something out of me. I don't know what it was. And I'm like appalled. Like, how could you not know what they took out of your body? How could you not know what kind of surgery you had, And this is why it goes back to, as a consumer, making yourself, you have to try and educate yourself about your disease process, your ownership in your disease process, and the things that you can do to assist a physician. Now, if they've exhausted all relative possibilities, I know if it was my child or my husband or my loved one who has whatever kind of disease, you're going to be, you bet your life I'm going to be hitting the books. And if I got to fly to Norway because some doctor over there believes in doing X, Y, and Z, I'm going to try it. You know what I mean?
Yeah. You are a consumer of healthcare,
Yes.
and make no mistake, it is a business of
Mm-hmm.
healthcare, and
Yes.
the pharmaceutical companies are publicly traded on the stock market, like
Yes.
very capitalistic supply and demand model.
Absolutely.
And in this place, we are the consumer, and you want to be an educated consumer. The other piece of that I really like that you brought up is the doctors let off the hook of the standard of care. And that languaging, I think, is really important because it's like it's almost holding back in a lot of ways. And
Mm-hmm.
I haven't told you this yet, Laura, but
Mm-hmm.
when working with clients, I have a 100% success rate getting
Mm-hmm.
physicians to not only okay alternative treatments, and by the way, alternative is alternative to the standard of care. Anything
Correct.
alternative to the standard of care is considered alternative medicine. And
Mm-hmm.
and so I've had a 100% success rate in doing so. And the
Mm-hmm.
way that is done is there's something called the tenets of medical ethics. I'm sure you're familiar with this.
Mm-hmm.
And they're
Mm-hmm.
ethical principles in medicine. The very first one is patient autonomy, and it states the
Mm-hmm.
patient has the right to refuse and to choose their treatment.
Yep.
So the trick is, and people don't know this, so they ask their physician. They say, "Hey, do you think this is a good idea for me to do this alternative treatment?" And if
Mm-hmm.
that physician has not extended or done all of the standard of care stuff, they're
Mm-hmm.
they're legally they legally need to say no, that's not a good idea because it's not part
Mm-hmm.
of the standard of care. But if you
Mm-hmm.
tell them, if you say, hey, I've done my research And the treatment I choose is high dose vitamin C.
Right.
Given intravenously.
Right.
At that point, then they are off the hook. They're off the hook because they didn't recommend the treatment. They didn't answer a question that said that was like, yeah, I think that's pretty good. You came in knowing what you wanted, and you asked for the treatment you wanted, and the patient has the right to refuse and to choose their treatment.
I would absolutely agree with that. And I would take it a step further and say, depending on, a patient can come in and suggest a totally ridiculous thing because they looked something up on Google, and if a doctor is worth his weight, whatever the patient proposes, whatever it be, he will take it into consideration and present the pros and cons to the patient and let them decide if this is a risk they want to take. Or in the case of vitamin C, there really isn't a downside to vitamin C. There really isn't. It's either the biggest downside is it just won't work, but it's not really going to harm you, So there's no downside to certain things, I mean, the stories of people like with terminal cancers who went on, they decided they could do nothing more for me and I should have been dead 5 years ago, but I decided to do this kind of a diet or, and did this plus acupuncture plus this, that, or the other thing. And here I am 6 years later, I'm still here. You know what I mean? These are people who are invested in making that decision. But I can tell you, we live in a society where people don't want that responsibility. They want to go to a doctor and be told. It's just appalling to me. Like, I can't imagine, walking into a hospital and not having any medical knowledge. People do more research on what TV to buy, than they do in what physician they choose,
Yeah, it's so true. It's so true. And that's, and I understand that people have their own priorities and are exposed to things. And the fact is, a lot of people don't want to think about something going wrong, and
yes.
This is where I really see the value in my work, in doing that work for people, in helping to advocate for them and helping them to advocate for themselves, coaching on that, and looking through the research to find the things and finding the practitioners that can help them the most.
Right.
So I was actually, I just Googled IV vitamin C and COVID-19, and what popped up was some things from, let's see, here's something from Harvard. And basically it says, yeah, it's possibly helpful, all this, but it also says this: there's no evidence that taking vitamin C will prevent infection of the coronavirus that causes COVID-19. High doses can cause a number of side effects, including nausea, cramps, and increased risk of kidney stones. And so it's not recommended. And
I don't know. Nausea and cramps is
right. It's
okay. And a kidney stone is easily treatable.
Yes.
You got to kind of weigh that out in your brain, right?
Yes, exactly. So it's not recommended by the FDA, but that doesn't mean it's not something that you can get and that can be beneficial.
Right.
Yeah, beautiful. And I really love that. I also teach physicians to, gently tell their patients that, I can't recommend that. But if you look at it and it looks like something you want and you specifically request it, then I can give it to you. Otherwise, I can't.
Right.
Just be honest. Tell them what's going on,
Right.
I recognize that a lot of people don't have the time to dedicate to researching and all the things that you and I both love and are passionate about,
Yeah.
But
yes, and I admire the work that you're doing. I admire the work that
Likewise.
you're doing, and being an advocate for these patients is phenomenal. You know, they have a voice. It's just like, you know, having a voice for your ends of life care as well.
Yeah.
You know?
Yeah. Thank you so much. And I I thank you so much for the work you do. Like I'm telling you, nurses are they make medicine go round, you know, like you guys are phenomenal, and you're just so passionate about the work, and it means so much. So I wanted to talk about one more thing. Well, maybe, you know, I won't say that. I want to talk about an interview that you sent me with Dr. David Katz.
Mm.
I believe he's a MD in Connecticut.
Yep.
Yeah, and
And he came and worked at Elmhurst and also the Bronx, I believe, during the pandemic.
that's great. That's great.
Yeah.
And is he retired?
Oh no, he's still
Okay.
working.
Okay. Yeah. So he said this, and this I thought was really, really powerful. He said the single leading driver of bad health outcomes is poverty. Social determinants of health are massively important. The 30 million people who are unemployed falls disproportionately hard on the people who can least bear unemployment. Those who are at most risk of food insecurity, those who are at most risk of depression, and those who are at most risk of addiction. First of all, do you agree with that statement?
I do.
Yeah. And now let's talk about economics, poverty, and health, and how
Yeah.
how is it that poverty shows up as bad health outcomes, and what have you seen as a ER nurse in Queens?
If you're impoverished, you don't have enough money for good food. Forget about good food. Sometimes you don't have enough money for food. And when you do get it, it's generally you're talking about empty calories. You know what I mean? They're not nourishing calories. So the most impoverished, if they have $5, they're going to spend it on $5 worth of rice and beans. Well, you may be getting some protein from the beans, but filling your belly with rice, So now these people who develop, you can be malnourished and obese.
Yes. Yes. In fact, most obese people are actually, probably all obese people are malnourished.
And then what do they have? They become obese and they become diabetic.
Right. And diabetic, you have this roller coaster blood sugar spikes and dips that are like that leave you insatiably hungry when you have a blood sugar dip. And then these spikes that go up, and not to mention what that does to your brain. Blood sugar spikes and dips are very hard on the brain.
Yes, it's appalling. It's appalling, and it's very sad. And I don't know how opening up the country is going to look, both financially and health-wise. I have no idea. And honestly, I think even all the powers that be, they can only make educated guesses with the data in front of them, because we've never been through something like this,
Right. And at the same time, we talked about how this disease is spread through droplets.
Right.
So people need to be in close enough proximity to have droplets from the respiratory system or from their saliva or things of that sort to come into contact with another person. And I lived in New York for 8 years. I am well aware of how you get on a subway, you're packed like sardines on that thing, especially if you get on like Times Square or whatever. And in New York, there's no getting around being in close quarters with people.
Right.
But in rural areas, that's not really the case. And
Well, yes, I agree. There is a false sense of security to that as well. And I think it's going to have to be carefully measured and watched. You know, in a rural community, I think you can open up things, provided, you know, as soon as cases pop up, they're kind of contained. They're made aware of, and it's not to minimize that, you know, community spread.
yes. Additionally, and like we talked about earlier with vitamin C being so powerful, I mean, the number of new cases in China is way lower. The number of deaths is way lower, like a tenth of what we have here. And my understanding is they're using high dose intravenous vitamin C to treat things. So I mean, I don't know. It's something that we should be looking into. And the other aspect of that is I wanted to talk with you about fear. And this is you know, it's serious disease. It's serious.
So I think the way to approach this thing is to have a healthy respect for this thing, okay? Because it is a deadly virus. But I think that the average prudent person can mitigate their chances of getting it. I think they can mitigate it. People need to know that it's within their power to maybe mitigate how badly sick they are, and to mitigate even your chances of getting it. Now, I mean, we all know people who are just slobs to begin with, right? They're just slobby people. They're not very clean. And chances are, you know, they might get this thing, okay? I think if you're prudent about keeping a certain amount of cleanliness about your own person and about your environment, you know, all of our nurses have go home to families. We all have a ritual when we get home, you know, taking off our clothing, you know, when we get to the door, you know, bagging it separately, washing it separately, showering before we come in contact with the rest of our family. You know what I mean? So it's you have to take some ownership of it, and the rest is just your hope, you know?
Yes, absolutely. Well, I appreciate you so much, Laura. Thank you for taking time to have this conversation with me. And
yes, I'm very grateful to Ta for hooking us up, and it's been wonderful to speak with you. And I'm very impressed with the work that you're doing, and I'm very impressed with your life story. It's very impressive.
Thank you. And you know, we'll be in touch. And I absolutely love being connected with nurses, because there's a lot that you see being in the medical industrial complex, if you will, being on the front lines of medicine in this country, which is phenomenal when it comes to critical and emergency care. Like I've never seen anything like it. It's amazing. And then there are aspects that aren't so hot, you know.
Yeah. It's a broken system. It's a broken system,
right.
You know. But you are a cog in the wheel, and you have to do the best with what you have, and make a difference in the little space that you occupy. You know what I mean?
Well, you do that every day. You do an excellent job, and
well, thank you, and so do you.
I can feel your passion. Thank you very much. And I'm working to bring us together, bring, you know, nurses and doctors and practitioners and advocates and patients all together in order to shift things bit by bit to be more successful, because lives are worth far more than any capital shareholder stock price.
Absolutely.
And I think that soon enough we're gonna see some big changes happening, and I'm hoping that COVID can be a catalyst to some of this.
Maybe.
Maybe.
I hope so.
Who knows?
I hope so.
Well, only time will tell.
Right.
And what we do to make things happen.
Right.
All right. Well, thank you so much, Laura.
Thank you.
So this is the empowerment series. Stay empowered. Most important thing you can do for your health, for your family, is empower yourself and know that you hold the keys to your health. Thanks a lot.
Amen.
I'll see you next time. So thank you guys for sticking around. Of course you're sticking around. That was awesome. That was so good. Every bit of it was so valuable, and I have so much respect for Laura and the work she's doing and emergency medicine in this country in general, what they're doing in this place. I am so happy to be bringing these interviews to you, and I'm going to continue. So if you want notifications on that or whatever, you can head over to my Facebook page or like Adventures in Brain Injury on Facebook and or Feed a Brain on Facebook, and you'll be notified. So thank you so much. Again, if you're enjoying these or you're hating them, I don't care. Head over to iTunes, leave me a review. And if you are enjoying them and you'd like to support me, head over to patreon.com. You can do so there. You can throw me $1 or $2 for every episode. It helps me out a lot. All right, guys. I will see you on the next one. Next time, we're going to get back to my interview with Dr. Alex Vasquez. I just really thought it was important to get you guys this interview right now. All right. See y'all later.
Someone take me to a doctor.